Hi, everyone. Welcome to our May case study. My name is Dr. Kelly Ruef, and I am a clinical consultant for Precision Analytical. This month, we're talking about a woman who has hypothalamic amenorrhea and osteopenia. So this will be a really fun one to go through. All right, so this is me, and my Instagram is Dr. Kelly Ruef. So our learning objectives today are to discuss functional hypothalamic amenorrhea. So, what is it? Learn about how FHA or functional hypothalamic amenorrhea, how it contributes to osteopenia, and then review a Dutch Plus case study. So first, let's just introduce Lucy. I'm just going to call her Lucy. So she is the young woman who is going to be our case study. And let's just pretend that Lucy is your new patient. And all she's given you is her Dutch Plus results. So I actually talked to a lot of practitioners during consults who have never met their patient before, and they just have their Dutch Plus results and their requisition form. So it's interesting to kind of go through the process of looking at the requisition form, understanding what the test results mean, and then coming up with questions. Like, what questions are you going to ask Lucy when you see her? So how are we going to interpret her report? What questions are we going to ask her? We'll make a list. And what additional workup are we going to do? All right, so she's in her late 20s. She's young. And on her requisition form, she lists that she's been diagnosed with adrenal insufficiency, hypothalamic amenorrhea, SIBO, osteopenia. She suspects hypothyroidism, even though she's taking levothyroxine. And she says she's got severe anxiety and trouble sleeping. So her BMI is 19. And remember, healthy range is 18.5 to 24.9. I know BMI is not the best marker, but it can kind of give you an idea of body weight. So she's at the lower end. She's at the lower end. Just keep that in mind as we go through this. And of course, I said she's taking thyroid medication, levothyroxine, and melatonin, probably because she's having trouble sleeping. So let's talk about hypothalamic amenorrhea first. So these two terms are used interchangeably. That's kind of probably something good that's good to know. So hypothalamic amenorrhea is also called functional hypothalamic amenorrhea. I'm going to call it FHA, so I don't have to keep repeating that long word. So first, it's good to know also that FHA is a diagnosis of exclusion. So what does that mean? That means we have to rule out other causes to her amenorrhea before we can diagnose FHA. So here are some other causes that can lead to secondary amenorrhea. And maybe just take a snapshot of this, put it in your notes. It's not a comprehensive list, but it sure does give you a lot of things to think about. And it's good to know that FHA is one of the most common types of secondary amenorrhea. So a lot of women have amenorrhea just from this functional hypothalamic issue. With the lab findings, we typically will see low FSH, low LH. Remember, FSH and LH are gonadotropins that are released from the pituitary, and they are what tell the ovaries to make sex hormones. So a lot of times you see it low, which means the ovaries are not really making sex hormones, which makes sense because in amenorrheic women, they're just not cycling anymore. Their hormones are low. So we see low estradiol and low progesterone because she's not ovulating. So why would someone have functional hypothalamic amenorrhea? A lot of times you see this from like a low energy, like low calorie intake, anorexia, low leptin, low body weight, excessive exercise, and stress. Stress is a big one. So this study just shows how low leptin contributes to FHA. So leptin goes down from energy deficits. So like weight loss, when you're exercising too much, not eating enough, eating disorder, it actually causes your leptin to go down. And remember, leptin is a hormone made by the fat cells. that regulates energy balance by inhibiting hunger. So think about it. If you're not eating enough, if you're working out too much, you wouldn't want leptin to be high, right? Because it inhibits hunger. The body wants you to eat more. So leptin goes down, and then it impacts your HPG axis, and you tend to end up with low gonadotropin levels, which is the low LH and FSH. So stress contributes to FHA. This is a study that just talks about how stress can affect the HPG axis. It might be interesting to read. Okay, so what's happening? What exactly is happening with this hypothalamic amenorrhea? So we have, of course, we have the hypothalamus in the brain, and usually it secretes gonadotropin releasing hormone, or GnRH. So usually it releases GnRH, which tells the pituitary to release these gonadotropins, the LH, which is the luteinizing hormone, and the FSH, which is the follicle stimulating hormone. And these hormones go over to the ovaries, and they tell the ovaries to make estrogen, to ovulate, make progesterone, and to make testosterone. Well, let me go back to that. So what happens when you're stressed out, when you're exercising too much, when you're not eating enough, it tends to inhibit or lower this secretion, or just change the secretion of the GnRH. So what you end up with is low GnRH and low LH and FSH. So hypothalamic amenorrhea, it's a form of hypogonadotrophic hypogonadism. That's the kind of official term. So remember the female athlete triad. So the female athlete triad is an interrelationship of menstrual dysfunction. So sometimes women have these irregular cycles. Sometimes they just are completely amenorrheic, no cycles, low energy availability. So that's with or without an eating disorder. And then decreased bone mineral density. Remember, our patient has osteopenia. So she's been diagnosed with this decreased bone mineral density. And it's relatively common among young women participating in sports. So some questions to ask Lucy. These are some questions we're going to ask that we want to know. When was the last time she got her period? So remember, secondary amenorrhea, you can diagnose it after a woman hasn't gotten her period for 3 months, if she usually has regular cycles, or 6 months if she's got irregular cycles. And this question, how much did you weigh back when you were still menstruating? That's a really important question, because sometimes women are like, oh, actually, I did weigh like 30 pounds more back when I was menstruating. And it could be that the weight loss is what is contributing to the amenorrhea. So regarding her weight, remember her BMI was 19, so it was on the lower side. And she's been diagnosed with SIBO. So whenever I see that, I always ask about the diet and eating patterns. So are there certain foods that she doesn't tolerate? Has she cut out certain foods due to SIBO? So sometimes women will still tolerate certain foods, but just because of the SIBO diagnosis, they might follow a certain meal plan or certain diet that cuts out a lot of foods. And you can see down here, these are some of the foods that women end up cutting out. And some of them are, all of them in moderation can be okay. And some of them are actually really full of sulfurous compounds and really important for our body and our liver and our detoxification. So let's also ask if she's got any fear or negative feelings around certain foods. I tend to see that with women who are diagnosed with SIBO who have a low body weight. And ask her, was your diet different back when you were menstruating? So she might say, actually, I was menstruating and then I was diagnosed with SIBO and I started following the SIBO specific diet and I cut out a lot of foods and stopped menstruating. That might be a sign, right? And of course, we want to ask if she's got a history of an eating disorder. Also about exercise, how often are you exercising and at what intensity? Are you doing HIIT training every day for 60 minutes? That might be a little excessive. What types of exercise do you do? Is it more like walking, gentle yoga, or is it more running, doing marathons, the HIIT training? Does she play sports? And what movement and exercise was she doing back when she was menstruating? So I always bring it back to when you were menstruating, what were you eating? Um, what movement were you doing? How much did you weigh? Because that can give you a lot of feedback, a lot of information about why she might be amenorrheic now. Okay, and then this is a big one. What stressors are in your life? So we know that even women who have regular cycles, if they have a certain week that's super stressful, it can throw their cycle length off. So sometimes women will have 28 days, 28 days, 28 days, 45 days, and then 28 days, 28 days. So stress is a huge one. Back when I was stressed out, the most stressful year of my life, my cycles were 17 to 45 days. That was how much they ranged. And I'm usually regular. So that's just an example of how much stress can affect your health and pretty quickly too. So I really like this. This is the Life Change Index scale that you can just Google and you can find, and it might be helpful to have people kind of check the boxes and you can understand a little bit about them if they have any of these major stressors in their life. Okay, so also ask, how is the osteopenia diagnosed? And what was your Z score? So remember, in younger women, we don't look at the T score. That's more postmenopausal women because that compares to a postmenopausal woman. The Z score from the DEXA scan is more of a way to kind of compare to women of a similar age. And so the American College of Sports Medicine, with a low bone mineral density, the Z score is between -1 to -2, with a secondary clinical risk factors for fracture, like chronic malnutrition, eating disorder, hypogonadism, which would follow that would be her hypogonadism because she's not making sex hormones, right? Okay, so how does this hypothalamic amenorrhea contribute to osteopenia? So let's go back. Let's go back to this chart here. So if you think about it, you know, all of these hormones here are important for bone health. Testosterone, estrogen, and progesterone. They're all important for bone health. It's incredible, but progesterone really is important for bone health. And there's research showing that if women miss an ovulation during the year, just not having that progesterone for that month can slightly affect their bone mineral density. Now, I wouldn't get too worried about that, but over time, if you're not ovulating and you just have low progesterone, think about your bone health. Okay. So if we're stressed out, if we're exercising too much, if we're kind of shutting down this HPG axis, we're going to have low sex hormones. So we're not going to have as much of these hormones around to protect our bones. This is a study that shows that cortisol, so higher cortisol in these amenorrheic exercisers is associated with a lower LH secretion. So basically, the takeaway is women who exercise and are amenorrheic tend to have higher cortisol secretion than women who exercise but still get their period. That is very interesting because we know cortisol, if cortisol gets too high, it can affect bone mineral density. Think about people who take prednisone long term or some other glucocorticoid long term. There's always that warning for osteoporosis or that increased risk for osteoporosis. So if we run around with high cortisol because we're stressed out, or because we're exercising and we're amenorrheic, or because you'll see in this next example, anorexic. Women with anorexia tend to have higher free cortisol levels in circulation. So if we've got this high cortisol long term, it tends to lead to low bone mineral density. Okay, so let's look at the Dutch Plus results now. So here is the page 1 of a Dutch Plus. This is the summary page. And if you've never looked at one of these before, we've got this little key on how to read the results. And for the estrogen and the progesterone dials, you'll see there's these 2 stars with a green band. So that is the luteal range. Remember, our reports are always in reference to the luteal range, which is, remember, the luteal phase is the 2 weeks before the period. And this little purple band down here, this is the postmenopausal range. So with the testosterone, with the androgens, with the cortisol, in between the two stars, it's not the luteal range, it's just the overall range for all of the ages. So we can see here, that's some low estrogen and low progesterone for a woman in her 20s, right? It's in the postmenopausal range. So this is page 3 of a Dutch Plus report. We can see the progesterone metabolites on the top right, the estrogen metabolites and the estrogen metabolism patterns down here, and then the androgens up here on the left. So her progesterone metabolites are low. And remember, when a woman isn't supplementing with progesterone or pregnenolone, then these metabolites can be used to accurately assess circulating systemic progesterone levels. Or I should say progesterone, it matches up with progesterone in the serum. So it's low, it's in the postmenopausal range, which, a lot of women, if they just haven't ovulated in the last 2 weeks, their progesterone will fall kind of near this range. So during the follicular phase, this would be probably a pretty normal result. So these are her estrogens. We can see her E1, her E2, and her E3 are all in the postmenopausal range. So they're low. They're very low for a younger woman in her 20s. And then here's the phase 1 estrogen metabolites. You can see here we've got the 3 dials, so the 2-OH, the 4-OH, and the 16-OH. These are all phase 1 estrogen metabolites. Remember, phase 1 and phase 2, a lot of it happens in the liver. And remember, phase 1 metabolites are a little more reactive, a little rowdy. They cause some oxidative damage. We don't want them in phase 1 for too long. We want to make sure they move over to phase 2 where they're more stable, more water soluble, more ready for excretion, more protective. So these are our little rowdy phase 1 metabolites. And what I like to do is look at the dials, like the numbers in the dials, and look at the pie chart, because the pie chart shows the relative ratios of these phase 1 metabolites. So it can kind of give you an idea of how much the body is pushing the estrogen down each of these pathways. So you want most of this pie chart to be green. That's good because that represents the 2-OH pathway or the CYP1A1 pathway. So here it is, CYP1A1 going to the 2-OH. This is the most protective of the phase 1 metabolites. I should say maybe the least damaging. Maybe that's a better way to say it. Because the 2-OH, it can also become a reactive quinone and cause DNA damage. It just doesn't cause nearly as much damage as like the 4-OH. The 4-OH, that's the one that we worry about becoming reactive, causing DNA damage, and increasing risk for like breast cancer, uterine cancer, prostate cancer. So if we look at the actual percentages, her 2-OH percentage, nice and high, really love seeing that. But the 4-OH percentage is above range. We want it below 11%, and she's at 16.8%. So that's high. That's too high in my opinion. Whenever I see a higher 4-OH, I automatically look over here at the methylation activity, because the 4-OH and the 2-OH, they get methylated in phase 2. That's how they get removed from phase 1 and they get pushed over, they get methylated over to phase 2. And so her methylation activity, it looks decent, but I might try to push this red arrow a little more to the right, a little more towards the faster methylation, just so we can help clear out the 4-OH metabolite. And the 16-OH, so her 16-OH percentage is 6.1. Our reference range is 13 to 30%. And in a woman, so I worry about the 16-OH being low, especially in a woman who has low estrogen, like her. She's got low estrogen and she's got a low 16-OH percentage and a low 16-OH dial. And that's because the 16-OH metabolite is more of a proliferative metabolite. It's more of a proliferative estrogen. So just imagine it binding to estrogen receptors and causing tissue proliferation. So if it's too high, you might get breast tenderness, you might get heavy bleeding, it might worsen fibroids or endometriosis. But if it's too low, it's not good for the bones. So, I mean, it even binds to receptors in the bones and supports that bone health, the bone mineral density, I should say. So the 16-OH, when that's low, I mean, 16-OH is not nearly as estrogenic as estradiol. So if a woman has normal estradiol levels, then I'm not so worried about a low 16-OH. But in her case, it's low. So this low 16-OH may also be contributing to her low bone mineral density. So we really want to figure out what's causing this amenorrhea and try to correct it so that she can cycle again and make estrogen again, right, to help her bones. So here's that phase 2 methylation activity. Remember I said I might want to kind of increase it. So the 4-OH metabolites, we said that the CYP1B1 makes the 4-OH. It's the bad pathway. And we said it could cause DNA damage and increase risk for certain cancers. This is interesting. So CYP1B1, this enzyme that makes 4-OH, it's found primarily in the breast, the ovaries, the uterus, the lung, and the kidneys, and a little bit in the liver. So not so great for breast cancer and uterine cancer risk, right? Because this enzyme is actually right there in the breast tissue, and it's converting estrogen in the breast to 4-OH, which can cause DNA damage right there in the breast tissue. So these are some questions. You might want to just take like a photo or kind of a snapshot of this, keep it for reference. When the 4-OH is elevated, either in the dial or the pie chart percentage or both, ask these questions. So number one, are the parent hormones elevated? Maybe some women just have really high estrogen, so their metabolites are high. So in that case, we want to try to lower estrogen levels. Could this enzyme that makes 4-OH be upregulated? We know inflammation, smoking, alcohol, certain environmental chemicals can push this pathway. It can also be influenced by one's genetics, so that might be interesting to look into. But a lot of times I have people just like list out all their household cleaning products, their lotions, their potions, their shampoo, everything they're putting on their body, and run it by the Environmental Working Group website to make sure that these products that they're using don't have a bunch of endocrine disruptors in them. And then, of course, is methylation low? Because if methylation activity is low, then the 4-OH isn't going to be methylated and moved into phase 2, right? It's just going to back up in phase 1. How do glutathione levels look? So at the back of our report at page 6, we have a glutathione marker. It's called pyroglutamate, and it can give you an idea about if glutathione is deficient or not. So sometimes I look back there to see how glutathione levels might look, because we know that glutathione and other antioxidants can kind of quench the 4-OH if it becomes reactive and protect the DNA. Other ways to support, so remember DIM and I3C. So they actually help push the protective pathway towards the 2-OH, but keep in mind that they will lower circulating estrogens. So I'm not going to use DIM in her. She's already got low estrogens. I don't want to try to lower them even more. If I use DIM in her, it'd be harder for her body to start cycling again. Sulforaphane can activate glutathione pathways, can support methylation. So sulforaphane is great if the 4-OH metabolite is elevated. And then, of course, overall detox with purified water, fiber, good bowel movements, cruciferous veggies, the carrot family veggies, rosemary, resveratrol. There's a lot you can do. Okay, so let's look at her androgens. So these are her androgen metabolites here. And we have the age-dependent ranges. So I highlighted her age. And look at this. The DHEAS is above range for her age. So that makes me wonder, okay, what do cortisol levels look like? What does cortisol look like? She says she's got a lot of anxiety. Maybe she's got a lot of stress in her life. Maybe she has high cortisol. Maybe that high cortisol is contributing to her amenorrhea. And maybe that high cortisol is contributing to her bone health issues. But these other ones are within range for her age. And if you look on page 2, so there's these 3 metabolites on page 2 that are not on page 3, so I always point them out. So make sure you always go back to page 2. Because especially the 5-alpha DHT, this is our most potent androgen. It's the active form of testosterone. So we don't want to miss it. So on page 2, she looks pretty good. I mean, her 5-beta is above range. This is a downstream. These two are downstream metabolites of testosterone, but they're not nearly as androgenic as testosterone or DHT or DHEA. but still, it's a little on the high side. So her androgens are a little on the high side. And it's interesting to note where androgens are produced in women. And you'll notice in cycling women, the adrenals make a lot of our androgens, like the majority. Like in a healthy woman, her adrenals are making more androgens than her ovaries. What contributes to high androgens? The ovaries can make androgens. The adrenals can make androgens. So if we're stressed out, if we have anxiety, it could cause our adrenals to make more cortisol and more androgens. A high body fat percentage, insulin issues, and here are some other ones here to think about. So what's contributing to her elevated androgens? So if I had to guess, I'd say high adrenal output, right, from stress and anxiety. And a lot of times when women are stressed out, if they have high cortisol, then I automatically think there's got to be some blood sugar issues, some insulin issues. So I always look into that. And then suboptimal clearance. She might not be clearing out her androgens effectively, so they might be sticking around. Okay, let's look at her adrenal panel. Yeah, look at this cortisol. Okay, automatically, if you look at these dials here, these tell you the total cortisol for the day, and this is the cortisol in circulation or in the tissues. It's high. Look at that. It's above range. And if you look at her actual graphs here, look at this. Waking above range, 60-minute above range, nighttime is above range. So she does have some high cortisol. But if you look at her metabolized cortisol, this gives you an idea of total cortisol production from the adrenal glands. So her metabolized cortisol is still within range. So that's a good sign. But what's happening, so when you see the metabolized cortisol within range, but the cortisol in circulation is high like this, that's we call it a hypometabolic pattern. So when these two dials down here, the saliva cortisone and cortisol total, when they're pointing relatively higher than the metabolites, then we know she's not metabolizing her cortisol efficiently. She's not clearing it out efficiently. She's actually keeping it in circulation. And we tend to see that with things that slow down metabolism rate. So hypothyroidism, low calorie intake, suboptimal liver function, and mitochondrial function. So it kind of matches up. If she's not eating enough calories, we're going to see this sluggish metabolism. And we're going to see her free cortisol staying high in circulation. And we tend to see this pattern in anorexia. Remember that study that said that women with anorexia tended to have high free cortisol? Well, it's probably because they're not clearing it out efficiently. Okay, so this just says that she's got high free cortisol in the saliva, and the saliva free cortisol represents the circulating free cortisol. So she's got high cortisol in circulation. And if we look at her organic acids on page 6, I mean, they look pretty good overall. Her melatonin is above range, but that's just because she's taking melatonin. And remember, anything you take orally goes through first pass metabolism in the gut and the liver. And so what happens is you take oral melatonin, it spills over into the urine. A lot of it gets metabolized right away in the gut and the liver. It spills over into the urine, so we get these falsely high levels. So when you see this above range and it's really above range, but they're taking oral melatonin, it's okay. And it doesn't mean they're taking too much, right? It doesn't necessarily mean they're taking too much. And her dopamine's a little low, but I usually only treat this if they have symptoms of low dopamine, like if they're tired, depressed, low energy, low libido, hard to get going. Okay, so here's a summary of our findings. Okay, low progesterone, right? Because she's not ovulating. Her estrogen is in the postmenopausal range because her HPG axis is just shut down. And she's pushing her estrogens down this CYP1B1 pathway towards 4OH. We don't want that, remember, because the 4OH can cause DNA damage and increase risk for certain cancers. Remember that CYP1B1 enzyme, it's actually in the breast tissue. It's not good. She's got some high androgens here. We found above range DHEAS and 5-beta androstenediol, so some higher androgens. And let's see, high free cortisol in circulation. And this hypometabolic cortisol pattern, which remember we see that with hypothyroidism, low calorie intake, sluggish liver function, and sluggish mitochondrial function. So here are some additional labs that we could do. Of course, I want to look at her gonadotropins, right? Her LH and her FSH, because with hypothalamic amenorrhea, these are going to be low. We want to just double check her estrogen. I always run estradiol with FSH because if estradiol gets really high, it actually suppresses FSH. Remember, because FSH is what tells the body to make more estrogen. You know, it's follicle stimulating hormone. It helps the follicles grow and make estrogen. So, but if estrogen's already high, it's going to suppress that signal. It's going to suppress FSH. So if you only look at LH and FSH, you don't look at estrogen. If it comes back suppressed, you might be like, oh, you know, it's low. She's got hypothalamic amenorrhea, but it might actually be because estrogen is high. Okay, so prolactin, we're going to look at prolactin because sometimes if prolactin is high, you have high androgens and you've got amenorrhea in some women. We'll do some general labs like a CBC, a CMP. The CMP will have the fasting glucose, the lipid panel. This is a marker of inflammation, and then the A1C, the fasting insulin. We want to look at her blood sugars. A thyroid panel, even though she's taking thyroid medication, we want to make sure it's the correct dose, right? If it's not enough or if it's too much, it can affect her ability to cycle. Okay, plus if she's taking too much thyroid medication, that's not good for her bones either. And then vitamin D, because we know if vitamin D is low, it can further worsen bone density because we need vitamin D to help absorb that calcium, the calcium that we eat through our gut. You know, we're going to refer her to gyne for a PAP and a yearly women's physical. If she hasn't, they might do a transvaginal ultrasound just to kind of get a visual. And referral to counseling, maybe a nutritionist who works with women with eating disorders if we find out she's got an issue there. And then if FSH, if it comes back elevated, we might want to test AMH. I mean, either way you could test AMH, but AMH can help estimate ovarian reserve, and it's an early marker of ovarian damage. So if AMH is less than 1, then we might look into POI. So remember, POI is primary ovarian insufficiency, and that happens when the ovaries don't respond to the brain anymore. So a lot of times FSH is elevated. So FSH is high. It's because the brain is screaming at the ovaries, hey, ovaries, make estrogen. But the ovaries are they're like, nah, we're going to retire. We don't want to make estrogen. You know, a lot of times we don't know why women have POI. We're not sure why those ovaries aren't making estrogen. Okay, so here's a sample treatment plan. And of course, this plan might change based on serum lab results. So here we've got this multivitamin. We just want to get more vitamins, more B vitamins to support methylation. Molybdenum here. Molybdenum is a really important cofactor for sulfation. So we might want to be supportive there. But basically, we want to get more minerals, more vitamins into her body. She could be deficient there. And then cortisol relief. Vitanica makes a really nice supplement called cortisol relief. It's got some L-theanine, some phosphatidylserine, which can help lower cortisol. It's got some great adaptogens like ashwagandha in there and some other things that are more calming to the system. So kind of supports that parasympathetic nervous system. And then Relax Max by Zymogen. You can see here it's got some other relaxing, calming support like GABA, L-theanine, taurine. Taurine can be really calming. And myo-inositol can be really calming. A lot of people use it for anxiety, but you can also use it to help regulate blood sugars. So if she does, in fact, have some blood sugar issues that are contributing to her picture, maybe to her higher androgens, the myo-inositol can come in handy there. And vitamin D drops. Likely she's low in vitamin D, and we want to support that. We want to support her bones. Here's a sample tea. It has nettle leaf, horsetail, oat straw, peppermint leaf, and ginger root. So the peppermint and the ginger, that's more to make it taste better. But the nettles, the horsetail, the oats, those have a lot of minerals in them, a lot of vitamins. So it can help with bone health. Okay, so calcium-rich foods and vitamin C-rich foods. These are going to support the bones too. Sometimes I'll add in actual calcium. I might do 500, 600 milligrams a day of calcium in addition to these calcium-rich foods. I know people used to do about 1,200 milligrams of calcium, but I don't think that's recommended anymore. I think it's kind of lower amounts but there might be certain situations where you use higher calcium. But a lot of times we're doing the 500, 600 milligrams of calcium, and then we're adding in foods to supplement for the rest. Vitamin C, major antioxidant, but also very important for the bones. And then we might want to calculate her basal metabolic rate in order to learn about her caloric needs. So for her basal metabolic rate is 1,380 calories a day. So if she was sedentary, she'd have to eat 1,650 calories a day. If she was really active, she'd have to eat almost 2,400 calories a day. So of course, if she's got an eating disorder, if she's got issue with weight or with food, I'm probably not going to talk about calories. But for my own knowledge, if I want to see, okay, how many calories should she be getting, and if I look at a dietary like journal that she's taken, I can kind of compare. Okay, is she getting enough calories? And here we go. If you go to Healthline, actually has this. What is basal metabolic rate? You can calculate this for your patients or for yourself. And then we're going to add on some more stress reduction. So there's this app called Healthy Minds. I love it. It's donation based. So it's free. If you love it, you can make a donation. But it really helps to kind of learn more about how you can train your brain, how you can practice mindfulness, how you can practice awareness, compassion, just to help lower the stress in your life and improve your happiness and maybe get your period back. So here's a summary. We've got the multivitamin. We've got a lot of stuff to just really help lower that cortisol, to help with her anxiety. We're going to think about some other things for bone health, like the vitamin D, the calcium, the vitamin C rich foods, the tea. Just lowering her cortisol is going to help her bone health too, right? Plus, if she starts cycling again and making hormones, that's going to help her bone health. And we definitely want to refer her to gyne if she hasn't been there in a while. Might think about transvaginal ultrasound, might think about sending her or referring her to a nutritionist who specializes, or a therapist, I should say a therapist who is great at working with people with eating disorders, because I personally don't have experience with that. So I'd be referring. Remember, we're a team. We can refer. It's okay to refer. Okay, that is it. That is our case study. Thank you for watching. If you have any questions at all, you can email info@dutchtest.com. I hope you got something out of this. And yeah, thanks for watching.